Are we live?
You are live.
All right. Hopefully, okay. New computer, so hopefully this will be. We'll have a better. Can everyone hear us now? Let us know if you're having trouble hearing us. Okay. So we're live with questions. We're live for questions.
Hello, I just want to introduce myself. I'm Camila Masias, and I'm a hematologist in Baptist Health in Miami, Florida. I did my fellowship at Ohio State University, where I stayed as faculty.
Thank God.
And then I moved to Miami. And I'm so sorry about the hearing problems from the last talk.
I promise.
So,
yeah.
It was an excellent presentation, and hopefully we can solve all your questions now.
Yeah, it's usually a much better presentation.
All right. All right. How do you know what a safe ADAMTS13 level is?
Okay.
So
That's a good question.
here, I'll unmute myself. How do you know what a safe ADAMTS13 level is?
All right. So the first question is, how do we know what is a safe ADAMTS13 level? Simplest one is the extremes. Someone has greater than 75%. We're done, right? We know that that is considered normal. That's considered more than adequate. On the other end, less than 10%. That is what is going to markedly increase the risk for relapse. In between then, yes, there is a gray zone. If someone has an ADAMTS13 level of greater than 20%, I think many people will feel that is high enough to prevent a relapse of TTP. However, at the same time, we do know that having persistently lower levels, 20, 30, 40%, can increase the risk for strokes. So we would prefer normal. That's the easy answer. But if it comes to doing things like plasma exchange, high-dose steroids, use of caplacizumab, once it's above 20%, then I think then the data would support that we do not need to continue those treatments because the risk of relapse for TTP, for the thrombotic microangiopathy, is practically non-existent.
Yeah, I would like to add that I think when we call about normal levels, yes, we have sort of the set limits, but also every patient is different, and we really have to look at the trend on every patient. Once they're in remission, some patients live just fine with sort of borderline low levels, and they never get into any trouble where, we may see a drop on a patient that has very high levels, and then they drop, and that's when we worry that they may have a relapse soon.
Is there a study working on isolating inhibitor and shutting it down without shutting down the entire immune system?
No. We are not that smart. We are not that good. There are ways to, in theory, if you could specifically isolate the antibody, there is in the laboratory a way to sort of go back and the antibodies, the cells that are making that antibody, in theory, to go back and particularly kill that specific antibody. But that is something that is not available in production. There are more targeted agents. So rituximab represents probably, compared to steroids, compared to Cellcept, compared to vincristine and some of the older medications, rituximab is more targeted. And there are case reports of use of even more targeted agents, something called daratumumab, that has been used in patients with refractory inhibitor formation, but specifically targeting that one B cell, that one plasma cell that's making the autoantibody. No, we do not have that yet.
And I can see here, Dr. Watson, when insurances are not covering rituximab unless we're actively relapsing. So now preemptive dose, what are our options? That's an excellent question. I think that we all count or rely on rituximab to prevent relapses. I think every situation is different. I don't know what would be if it's covered more inpatient versus outpatient. I would say definitely if it's not covered, maybe a closer surveillance of the ADAMTS13 activity would be, and your platelet count and your hemolysis marker would be ideal to sort of, if you relapse as soon as possible. And then the other alternative that we've used for relapse prevention is called cyclosporine, and it's an oral therapy that is also aiming at suppressing your immune response, and we've had really good success. So that would be something else to inquire if the insurance covers it or not.
Yeah. I'll take the next question. Okay. All right, the next question is, does an ITTP patient tend to have cycles of relapses? My first relapse was 2.5 years after my diagnosis, and my hematology mentioned that might be the course of my disease. So yes, I mean, before disease used to be 100% fatal. And, now the silver lining of reducing that is that now we've been able to turn this into a chronic disease. So in a sense, like asthma, like diabetes, there can be ups and downs. And for patients who have persistent ADAMTS13 deficiency with persistent inhibitors, we're trying to get rid of those inhibitors. However, we do see in our patients who have recovered that pregnancy, viral infections, or just sometimes this happens, this comes back, which is why we recommend surveillance, that once someone has been treated at TTP, we don't just cut them loose and say, look, you're done, forget it. And so whether it could be yearly, it could be every 2.5 years, it could be every 5 years. I had a patient who went over 20 years before she relapsed. We don't know, but that's why we would recommend that you continue to get surveillance.
Yeah, and I want to introduce sort of another theory here that is called what we call the double hit. And what it means is that we have patients that have a normal ADAMTS13 activity, a deficient ADAMTS13 activity, and they don't relapse, but then something happens, whereas they get pregnant, they have a viral illness, and that's when they have a relapse. So I don't know if I would call it a cyclic relapse disease. More so than you need something else happening to trigger this relapse.
All right. So the next question is, do you ever reach a point to stop worrying if you had one episode but no further relapses? I'm going to be a jerk and say no. Because I never stop worrying. It is always on our mind because we are not that good. We are not that smart. We don't ever want to say, I don't ever say, yep, you had it once, goodbye. Go, don't ever worry about this. Now, granted, it becomes part of the past medical history. We don't let it inhibit, prevent, stop a patient from getting the care that they need. But because this is autoimmune, there's always the risk that it can come back. In which patient, at what time, we can't tell you. It does look like the longer that someone goes without relapse, the lower that possibility, that probability becomes. But we don't feel that it ever truly goes to zero, that, okay, once you've passed the 1 year, 5 year mark, it's never going to happen. We don't know that. And I don't tell my patients that. I tell them, like, look, there is always a chance this can come back. There's always a chance that this could happen again. But yes, the longer you go without it, the less likely that becomes. But we don't feel that ever goes to zero.
Okay. Is there a possibility that blood clots are still in our bodies after recovering from acute Ttp? That is a really good question. I think that the more we learn about this disease, we tend to think of it as Dr. Metjian was just saying, as a chronic disease with sort of ups and downs. And we know that there may, in some severe cases, be damage in the form of very small clots in our very, very small vessels. And that's why patients present with strokes or a heart attack. And when you've recovered from the initial episode, some patients continue to have some long-term complications. And one of the theories is that they may be having this sort of microthrombi. But that's all under research. I can't say for certainty that that's the cause of all the problems that we're seeing long-term. But certainly it is a possibility and something we're looking at.
Are recombinant ADAMTS13 is recombinant ADAMTS13 resistant to autoantibodies? Probably not. That is why at least the slides that I left out of the talk, for in the interest of time, in the SOAR high studies, they are using recombinant ADAMTS13 for congenital TTP, obviously, which makes sense, immune TTP, and also for sickle cell disease. We do know that the autoantibodies will bind to it, whether it's the ADAMTS13 we are making inside of us or the ADAMTS13 that's being infused. And that's why in the study there needs to be continuous infusions of ADAMTS13. But like plasma exchange and like the use of caplacizumab, at the end of the day, the issue is the autoantibody production. So all the recombinant ADAMTS13 is not going to prevent, it doesn't deal with the underlying problem, which is the immune system creating an antibody against ADAMTS13. And that's why we're sort of so gung-ho with immune suppression.
Where do you see research going in the next 5 years with regards to new understanding and treatments of TTP? Yes, so I think that focusing on immune-mediated TTP, I think that I would divide it in two parts, maybe that where I see the research going. One is in the therapeutic part, and I think it would be great if we reach a point that in which we don't have to treat patients with plasma exchange in the acute phase, having to admit patients, put them on, having to insert a central line and do plasma exchange for several days carries a number of potential complications that we would like to avoid. I think it would be great if eventually this becomes an outpatient treatment, and that's what we're working on, or that's what we're trying to figure out in this upcoming study in the use of caplacizumab plus or minus plasma exchange. And then the other sort of area that we're focusing our research is on these long-term complications. Patients are not in acute episode yet. They tell us they're having trouble concentrating. They are having memory problems. They have a high risk of depression and a number of other complications, high risk of high blood pressure. And we're trying to understand. I think our understanding of those complications are better than 5 years ago. But eventually, where we want to get to is where we can find a therapy that is going to prevent all these problems.
And I'll take the next question here, but I want to add on that, if you were able to hear my presentation, in terms of the pathogenesis, we still don't know what is the reason or what are the reasons of all the enzymes in the human body. What is the reason that ADAMTS13 is targeted by the immune system? Like Dr. Masias said, will plasma exchange be replaced by caplacizumab? And we're going to see that with the phase 3 clinical trial of Mayari trial. So for people who didn't hear, that is a clinical trial that's going to compare the use of caplacizumab versus plasma exchange head to head. So if there's a chance, unfortunately, if anyone relapses or anyone who develops TTP and this trial is available at your center, please consider volunteering for that study. We also don't know for those patients who have refractory inhibitors, is there a combination of chemotherapy, of immune suppression agents that will work? The use of rituximab, dexamethasone, cyclosporin, cyclophosphamide. We don't know what works. It's just what people have done. And what I'd like to also segue into the next question, like Dr. Masias had also said, the next question is, do you ever see memory loss, particularly short-term memory, and lack of focus as one of the long-term effects of acute TTP episodes? So one of the things I talked about in my prior presentation is that what we call issues with survivorship. Do we have patients who have problems with memory, concentration, mood, Definitely. These are, now that we have taken it so that our patients are living, they're not dying in the hospital, and we're seeing them back as outpatients. Someone who says, I just don't remember anymore. I have to write everything down. I can't concentrate. It takes me forever to read a page. I'm just not the same as I was. We know that this happens. We know that patients have chronic pain afterwards. We know that they have symptoms of PTSD where they're worried, is my TTP back? Not that this is normal, but this is expected. There's nothing wrong. We know that this happens. And I'm on the lookout for this because you hear this. And there is, how do we treat this? We are learning as we are going forward because we've taken this near fatal disease and turned it into a chronic one. So I will ask my patients to, if they have symptoms in the hospital, I get a baseline MRI. And then 6 months later, I get another MRI to see if there's been any changes. I ask my patients to undergo neurocognitive testing. I ask them to see a psychiatrist or a behavioral therapist or a psychologist if they're having these symptoms, because we know that this happens. We are on the lookout for them, and they don't get better if they're not addressed and they're not treated.
How safe is pregnancy with TTP really? Another great question, and we're going to have a dedicated session this afternoon on women's health and
with the expert.
And I'll be in that session with Dr. Anton and Dr. Berwick, who is an GYN OB-GYN from Cedars-Sinai in California, and will be. But short answer is it can be safe. It just requires planning and monitoring, and we'll discuss that at length later.
Okay. Next question. Should you worry if after a relapse, your platelet levels are always high? It's probably not what you're asking, but if someone has ever had their spleen removed, no, I don't worry whatsoever because we know that happens. That doesn't worry us whatsoever. After many patients, after their acute episode of TTP, their platelet count skyrockets. There's a rebound thrombocytosis. And then eventually and then for vast majority of people, it does eventually start falling. We know this happens. The platelet count dropping from 500 to 300 to 250 is not a concern because we know that platelet counts oscillate. Now, I guess the devil is in the details, but usually the platelet count goes back to where it was before, and it will go up and down. It bounces around. Like I tell my patients, the platelet count is not like the number of teeth you have, the number of bones. It goes up and down. But as long as it's not, if it's persistently high, like in the 700s, 800s, yes, there are other things that could cause it to be elevated. But if it's just a little bit elevated, no, we don't worry because it usually goes back down. That's twice. Let's go to the next question.
When do you know you are formally in relapse? So relapse is defined by a drop of platelet count, what we call laboratory tests that confirm hemolysis. Usually those are an elevated LDH, and some findings that we see on the blood when we look at it under the microscope, and we see these schistocytes, which are broken red blood cells. And that has to be accompanied by severely deficient ADAMTS-TS13 activity to less than 10%. Now, that is the clinical definition. But patients that have a history of TTP, they may, they feel they don't feel well. They have headache. They may have headaches. They may see bruising. For one reason or the other, some patients tend to feel these they just feel uneasy, they don't feel well, and usually they know when they're either about to have a relapse or having a relapse. But that definition is what I just said. And when we see those findings, we have to act right away and start plasma exchange and steroids.
All right. And next question is, how long after having rituximab infusion should I wait before getting a COVID booster? At the very least, 6 months, probably a year. And it's not because the booster would be harmful. It's not as though getting vaccinated would be dangerous. It's just unlikely to be effective. Specifically within TTP, I mean, the studies have not been done, the data is not there. We extrapolate from patients who've had lymphoma or other hematologic malignancies who've received rituximab. And we just know that if we are suppressing the immune system so that the immune system doesn't make an antibody against ADAMTS13, well, we're not shocked if it doesn't make an immune response against the COVID proteins. So, even though in this day and age we're worrying about it, basically, if you've gotten rituximab and a month or 2 or 3, you go to get your COVID booster, all you're really doing is getting a hole in your arm. It's really not going to be, it's not going to be that beneficial.
Yeah, and I think that that's where maybe planning come into play. If you are not having a relapse and you feel fine, your labs are okay, and you are getting rituximab because other than that, your ADAMTS13 maybe is trending down, and your hematologists think that rituximab may prevent relapses in the future, you may get a booster before getting the rituximab. Because the other part of the story is that we know that patients that receive rituximab are at a higher risk of developing COVID. So we do want to protect these patients by, if possible, and anticipated giving them a vaccine or the booster beforehand. What is LDH and when should it be checked? LDH is a laboratory marker, lactate dehydrogenase of, as I was saying, hemolysis, and it's a marker of red blood cell destruction that occurs not only on TTP but on other diseases. And it definitely should be checked when we suspect a patient has an acute episode of TTP. And we oftentimes check it periodically when we see patients in clinic because, as I was saying, we're trying to sort of anticipate and get us ahead when we try to prevent relapses, or not prevent them, but detecting them early. So this is something that sometimes we check in clinic every 3 or 6 months when you see your hematologist.
Next question is, can you talk about the destructive effects of prednisone used in treatment of TTP and potential alternatives? So, yes, I mean, prednisone it's like making a deal with the devil. It's cheap, it works, we've been using it for decades, and there's a laundry list of side effects, from neuropsychiatric, cardiac, endocrine, muscle-mediated. There are innumerable side effects. We use it because it works quickly, it works well, it's dirt cheap, and in combination with something like rituximab, it's the backbone. Steroids, rituximab is the backbone for not only many lymphoma treatments, but also for TTP treatments. We know this, and ideally, once someone's ADAMTS13 levels have started to rise, then we start the taper of prednisone. And invariably for many patients, even if the ADAMTS13 level has not risen, if we haven't seen a budge after about 2 to 4 weeks of high-dose steroids, I will frequently start the taper and say, look, there's something else. Are there potential alternatives? Many. Rituximab, that's just the starters. But if you go through this, there are so many other things that have been used. And what is more effective than the other? There are some people from Ohio State who love the use of cyclosporin, and there's good data that shows Dr. Catalan, who is speaking here, has pioneered the use of cyclosporin in the treatment of TTP. However, there are many other things that have been used, like azathioprine, cyclophosphamide. I mentioned something called daratumumab, which is a medication that's used for myeloma, mycophenolate, vincristine, even splenectomy. All of these have been used for those patients who have not been able to eradicate their inhibitor. But for many patients, if steroids led to intolerable and just unacceptable side effects, there are other things that we can use. But to be honest, do we know that if I use vincristine, that is just as good as rituximab? No. Just due to the rarity of this disease, we rely upon case reports. But yes, if you've had steroids and it's led to intolerable side effects, I will not use it again. But we'd have to have a very long talk about what else we could use. But it is not. You're not destined to only get steroids if you've had a bad effect with it.
And I also want to add that I usually tell my patients that I have a love-hate relationship with steroids because I mean they're extremely efficient. Prednisone does the work, and I think it's key to have a short course, right? Nobody, at least with a history of TTP, should be on steroids, certainly not indefinitely, and certainly not for a long period of time, because the side effects that we see with steroids are most likely when it's used on long periods. If you had an acute TTP episode and you are on a short taper, as it should be, 4 to 6 weeks, that should be fine. And we're not going to see all these. You may have difficulty sleeping. Maybe if you're diabetic, your sugar may go high. But long term, you shouldn't have any long term side effect. And if you are still in the need of steroids because you're still relapsing after 4 weeks, definitely, we should have added something else way before to anticipate this problem.
Yes. Okay. Same question.
All right, well, it looks like we're about out of time. I just want to.
Oh, wow. Good timing.
Yeah, it was perfect timing. I just want to thank everybody who joined in. Thank you for your amazing questions, and thank you to our doctors. Yeah, that's me. We had some technical difficulties, so we had to rearrange. So we're out in the hallway, but we appreciate everyone and their time. So thank you.
Okay. Thank you, everyone.
Thank you.